Right. So corneoscleral tears can be, across a wide spectrum of size and difficulty, and we always need to have a few things that we assess before we plan it. One, of course, is the nature and mode of injury. Whether it is, what kind of injury, is there any other associated systemic injury there? These are medical legal cases, so the documentation has to be extremely clear and as pictorial as possible. If you have a photographic documentation, it helps. Of course, the patient's vision, whether it's a closed globe, open globe. So there are so many different things that you have to assess. Always look to see if there's any intraocular foreign body, because sometimes that may change our management. And of course, what all is involved. So not only the anterior segment, but always look at what all is involved. So very, very small or a partial tear, we need not always have to suture. But if it's a full thickness tear or a very deep, large tear, shelving tear, tears in children always need to be sutured. In the immediate phase, when we're looking at if it's an open globe, please avoid any topical medication. Start the systemic antibiotic. The most common antibiotic that we start is still oral ciprofloxacin, the age-old medication, but it works very well, very good intraocular penetration. So that is there. A tetanus toxoid injection is also useful, and shield the eye before you plan surgery. Most of the instruments that we need for these surgeries are already available in our OT, so nothing extra that we would require. The sutures we most commonly use for corneal suturing is a 10-0 nylon. However, for very large tears or if there's tissue loss, you may have to use thicker sutures, sometimes 8 or 9-0. And of course, a conjunctival or a scleral tear would require an absorbable suture like Vicryl. Usually they would be spatulated needles, so most of the time it's the same thing we do. The goals of a corneal tear repair is, of course, a watertight closure. That's the first goal, because we want to keep the globe intact. However, in that attempt, it shouldn't be over judicious, so that it's so tight that it causes a lot of astigmatism. So we want to try and maintain the contour as far as possible, unless there's a tissue loss, in which case you can't help it. Restoration of as normal anatomy as possible, and in that case, as much of visual acuity as you can, and further complications which can be of infection or other complications, as we'll discuss. Techniques are very simple, and we've all seen this before. One is, of course, when you are entering the needle or putting in the needle. That's with any corneal suturing. You want to keep the needle as perpendicular as possible so that you get a good depth, because if you're very superficial, then you'll get a lot of cheese wiring and also not get a good opposition edge to edge. Try to get an equal length of the suture on both sides, and this is only changed if it's a shelving tear where we are trying to make it unequal on both sides. The zones of compression is something which is very important to remember. So this basically means that each suture has an effect which is across a rectangular area of the cornea. So you have to imagine that when you are placing your sutures, there's going to be some overlap of those triangles, and that's how we space our sutures. But very simply put, basically you start at the limbus. Then if there are any landmarks, if the tear is jagged or has a particular shape, then you're going to put, and I'll show you in some videos, you're going to put the sutures at the landmarks first, and then go in between and put the sutures. So the reason being that this will help you get as close to a normal anatomy as possible. If you do not suture the landmarks first and just start from one end and keep suturing, sometimes there may be a misapposition of a particular area of the cornea. As I was saying, if it's a perpendicular wound, then you want to have it equal on both sides. However, if it's a shelving wound or an oblique wound, then one edge, you'll be closer to the where it's starting shelving, and deeper where further away when it's away from the shelving. Zigzag wounds are some of the most difficult wounds, and as are stellate wounds. So there are different techniques for suturing. One is this, where you're trying to put a mattress suture. You can also have cross sutures on the wound. So I'll just show, looks like a very, very small tear. So the first thing that we do, if it is a corneoscleral tear, is explore the area where it's entering into the sclera, because you're doing a peritomy to see the scleral end. Reposit any iris that may be there. Put the limbal sutures. Now this looks like a very small wound, and once the iris is reposited, you start suturing. But once you actually explore the wound, you will see that actually it's a very, very jagged wound. This was a glass injury, and so there were multiple jags at different areas. Not to be daunted by something like this, but you just have to, very patiently see where the breaks are and keep putting. The point in these kind of injuries is that there will be a lot of edema at the site of injury, so you have to put longer bites to try and avoid it cheese wiring. The iris may keep prolapsing, especially if it's an older injury, the patient has not come immediately, so the iris will have a memory which will keep coming. If it's a day-old injury, we do not need to abscise the iris. It can be reposited. However, if it's an older injury, then we may need to abscise the iris to avoid this thing. Now, one case which I wanted to show, which this gentleman presented to us, which was quite tragic, where he had a nail which fell into the eye while working. This eye was no PL at presentation. Very, very important. Even if you have an eye which has no visual potential, still our primary aim is to try and restore globe integrity as far as possible. Primary evisceration is to be avoided as far as possible. Otherwise, always try to restore anatomy where possible. In such cases where you're suspecting an IOFB or you already have an IOFB, imaging is mandatory. So if the patient cannot afford a CT scan, you can still get an X-ray and still medico-legally it is okay. But wherever possible, if it's a really bad injury, we want to see the bony edges, the bony markings, then you have to do some form of imaging. So here, it was a nail which had gone into the eye, so we really want to know, and obviously from the look of it, a very large nail. So we want to know if the orbit margins, the roof or back is intact, because if it has penetrated through the orbit, then you can't, the removal is that much more tricky. We have to involve a lot of other specialties, including neurosurgery. But here and get an official report, and here the orbital margins and bony orbit were intact. So it's a no PLI. So this is the technique which we can do. However, if there was vision in this eye, then this would have been much more tricky, because you can't just pull out a nail. So the first thing to do was that we couldn't even put in a speculum, so we had to gently just clean it. And you can see that it's a really, really large nail which has come out. It was almost 3 inches. You then go ahead and explore the wound. The corneal wound was fairly straight, but what I wanted to show here was the posterior extent of the wound, because the nail had traversed posteriorly. And the idea is to try and explore the wound and find the posterior extent, which is not always possible. In this case, even the lateral rectus muscle had got disinserted, and which is why I could actually retract the globe to the side and find the posterior extent as far as possible, and then reinsert the muscle. Now, even though it is not an eye which has visual potential, our idea is to give as much cosmetic or globe integrity as possible, and this is a painstaking procedure, but it is gratifying that we may be able to keep this integrity. And this is the patient post-op. You can see that the eye still looks quite well maintained. However, the chance of sympathetic ophthalmitis is very, very high in such cases, and it has to be warned to the patient. So always tell them that, otherwise they'll get complacent and not come back. So you have to tell them that the other eye can have a problem, and they have to come back and check for it. Removal of sutures can be done in the outpatient department, fairly easy. Posterior segment